Okay, so we're going to go on to the second part of our presentation here. And so this is part 2 of your coma lesson. We're going to talk about the coma scale. So Glasgow Coma Scale is just a way to, it's a tool that we use to communicate about coma. And it's based on 3 things: verbal responses, eye responses, and motor responses. So we talked before about that patient that I had in part 1. We talked about the patient that I had who kind of had this progression of coma during our therapy, which by the way is pretty rare. Normally, you know, we may lose that, we may see them in intensive care and they may be in a coma, but then maybe they aren't on our service, you know, after that. So that, I feel like that was a unique experience, that I was able to see that whole progression from him. The verbal responses are there's a lot of different categories, and you're going to explore these a little bit in the formative assignments section. So, but the verbal responses, you know, are they saying things purposefully? Are they saying things reflectively? There's different things like that. The eye response is the same, and then motor, are they moving? And so you're going to be reviewing the scale. There's a great Glasgow Coma Scale. There's a whole website on it. And when you go there, there's a really good video that you're going to watch that's going to teach you about how it's used and what that would look like. And then there's actually a self-test that you're going to take at the end. It's not a graded thing, but you're going to just you're going to get 5 points for showing that you did it and talking a little bit about how you did on the test. So make sure that you watch the video though before you do that, because it'll give you lots of information. All right, the Rancho Los Amigos is this functioning scale like I talked about, and it helps us to describe what patient's behavior is like. So we start out with no response. The person who's in a coma has no response to anything that we're doing. And then at the very end is purposeful and appropriate responses. So hopefully most of us are functioning on a day-to-day basis of purposeful and appropriate responses. So that's the very highest part of the scale, and then there's a whole bunch of things in between. We're going to talk about half of the scale. We're not going to talk about the things that are purposeful, more purposeful. We're going to talk about the things that are more reflexive, because that's more related to actual coma. Excuse me. It correlates with the Glasgow Coma Scale scores, and so that's why it's a really, you know, good tool for us to use. It just helps us to be able to get an idea. There's a lot of great resources out there about what kind of interventions to do with people at different levels, which we're going to talk some about that today. And then it doesn't tell us necessarily how everybody is going to progress. And the important thing to know with all of your patients is that everybody's going to progress differently. So you might have a person in a coma who never comes out of the coma. You might have a person in a coma who's in a coma for a few minutes or hours or days, and then they're out of the coma and they're fully functioning. Or there's a lot of things in between. So every patient doesn't go through all the levels, and every patient is a little bit different in how they respond. So the Rancho Los Amigos, by the way, is a hospital in Los Angeles that is well known for their traumatic brain injury treatment and therapy. And if you go by the lab, there is a poster on the lab wall. I believe we have that up. Well, I have it in my office. You can come see it sometime. But the Rancho Los Amigos, and I think it's on the lab board there by outside the lab. But Rancho Los Amigos has an art program, and so they have these patients who have traumatic brain injury and doing art. And so it's just a poster of different kinds of paintings that people have done while they've been in Rancho Los Amigos. So very OT. But the patient in level 1, it means they have no response. So they seem to be sleeping. They're not really responsive to anything. Even if we touch them, talk to them, move them, they're not going to respond to that at all. And what's the limiting factor? Well, they have low arousal in their brain, and we're going to look at brain, the parts of the brain that respond to that pretty soon. But this person really just doesn't even know we're there. But again, you still need to be speaking to them as if they do know that you're there. As the person progresses, they're going to move to a more generalized response, which means that they're not really responding particularly and specifically to something, but you're getting some kind of awareness that they are aware of you. So it could be that you do range of motion with the patient and they groan, or it could be that you come in, you start talking to somebody, and they start trying to rip out their all their monitors and their leads and everything, and that does happen. So a lot of times you'll see in intensive care that they will actually put restraints on people's wrists to help them not pull their things out. Because at that point in generalized response, they don't understand that they are pulling them out, and they don't even understand that they might be causing themselves pain. And so the restraints they're just a soft restraint on their wrist, but it's going to be it's a way for them to not hurt themselves, basically. They might have a response to painful stimuli. So if you gave pain, and if you do this on yourself, just put pressure on your nail bed right there, and you can see that it's a little painful if you do that. So they might respond to that kind of painful stimuli with just a general reflexive response. Maybe they're just restless in the bed. That can be that increased activity, and or they're just kind of vocalizing things or grunting or making a sound. It's not anything you understand, or it's not purposeful. It's just noises that they're making. And that's the generalized response. And we move then from generalized response to it is a more purposeful, it's called localized response. And localized means that I am reacting specifically to what you're doing. So if I gave you the nail bed, painful stimuli, you would pull your thumb away from me because you wouldn't want me to keep doing that. Or I would turn away from you while you're speaking right here to me because I don't want to hear you speaking to me. So it's very specific to whatever stimulus is being given, but it might not be consistent still. There might be blinking, they're following the moving object. So this is their eyes are open and they're able to follow the moving object, yet they might not be talking to me, or they might not be moving when I ask them to. And you could have eye responses without having verbal responses or without having motor responses. So they don't necessarily all come in together depending on the patient. And then at level 4, which is where we're going to stop this particular part of the lecture, but it does go on, I believe, 8 or 9 levels. But in the confused and agitated state, they are alert and they are more awake, but they are very confused. So you're going to come in, and this person is sometimes going to be combative. They're going to try to get away from you. They're really irritated at you. They're really they just want you away from them, but you won't really know why, and they don't really know why. It's just very, sometimes they are very aggressive in this stage. Your patients might be. And so a lot of times in this stage, we're using a lot of things like monitors and alarms on beds and wheelchairs. Sometimes they have specialty beds that actually hold someone in what appears to be a box, but the person sleeps in there so that they can't jump out of bed and run away. The thing about traumatic brain injury sometimes is that sometimes the patient physically hasn't really lost a lot of function. And so what happens is they are confused, but they can move. And that makes it dangerous. I had a patient one time who was in this confused, agitated state who could walk. And so I turned my back for about 3 seconds in the gym and to get something off the shelf, and he ran out the door and ran across the street. He ran out the door of the rehab facility, across a huge parking lot, across a huge street, and went over to the ATM at the bank. It was a very odd thing. He's standing there in his gown at the bank, at the ATM, without an ATM card. But he was very confused. He didn't know where he was. Thank goodness he didn't get hit by a car. But he was very, he didn't know how to do purposeful movement. He just knew that he needed to get out of there. So a lot of your patients in this phase are going to seem almost like somebody who can't be contained. And that's, just remember that that's their brain injury. That's what's, they're not doing it purposefully to be difficult for you, though it is quite difficult. But that's what's happening. So these are the lower levels of coma stimulation, coma levels, and then it's going to progress to more purposeful, calmer kind of behavior. So they might be confused, but then they might confused and appropriate. They're nice. They're not agitated at you. They're not aggressive at you, but they are still confused. So there's some different levels of that. All right, so coma in the brain. I just want to go through this a little bit. When we are conscious, we have chemical signals that are going all the time from the brainstem and the thalamus up to the cerebrum. So if you look at this picture here, you got your brainstem down here, and I think we have a picture of the thalamus in a slide or so. But essentially what's happening at this mid part of the brain, there's a system called the reticular activating system that is a filter for all of the sensory stimulation that's coming into our body. And the reticular activating system actually is very, it's important in sensory processing disorders too. So if you had a child or an adult who had autism, for instance, and had sensory processing difficulties, the reticular activating system is an important part of that, filtering out the noise that's happening in life. And some of us have a more difficult time doing that than others of us, and so our reticular activating system, or RAS, is not going to be working the same as for other people. But what the system does is it takes in all of this information, and it's the sights and the sounds and the smells and the work you're doing and all this stuff, and it puts it together, and then it sends out the important stuff up to your cerebrum, and that's where all the executive function, the thinking and the manipulation of the information, and trying to figure out, okay, the brain says, what am I going to do with that information, and sending back out the signals that tells us to act on the information. So when those signals are not strong, it causes us to go into a coma. When we're really focused and alert, then that's when our RAS is working really well and sending those messages really well. So that's how that looks. All right, so the brainstem we talked about connects the two hemispheres to the spinal cord. We talked about what that is. This is the picture of the thalamus. So the thalamus is right in the middle of your brain. And the thalamus is also, again, responsible for helping to send those signals to the cortex or the cerebrum. And so what our job is in coma, primarily, especially in the lower levels where it's more generalized responses, is our job is to provide stimulation for the patient to raise their arousal levels